you?
I'm doing well. I'm doing well. I am so excited we got to do this.
I know. I'm like so happy to meet you.
Yeah, I know. I meet a lot of people this way, but I'm gotta admit, I'm fangirling a little bit. I'm fangirling a little bit.
I'm
So thank you.
fangirling too. I was
This is
just
so cool.
telling some people at my job that, like, some of my coworkers, I was like, she gives like the most concise, like things about all of the different things we should probably be reading and like staying up on. So and so I was showing them your IG page and they're like, oh my God, this is like amazing.
Well, I think this is going to be a good discussion. I'm going to pause for a second though and introduce you because I turned this into a podcast afterwards.
Cool.
So let's pause you. I want to introduce you and then we'll go from there. We'll get into the good stuff.
Sounds good.
Okay, so today I am joined by Dr. Heather Irobunda, right? Yes. It's a thing. I like to pronounce people's names right. And I've had a very simple one. So I always want to make sure that I am respectful and it's important to me. So I'm glad I nailed it.
Yeah, you did it. You got it.
Okay. And you are an OBGYN in New York City, right?
I am.
And how are things in New York City right now?
Well, in terms of COVID, not terrible.
Okay.
It's what's crazy about what's going on in the other parts of the country, it feels a lot like what it was like in New York last year in the springtime. So, and it's scary. So it's kind of like, somewhat of a PTSD situation in terms of that, because it's like, oh, I know exactly what's going on. And it was not pleasant at all.
Well, we're going through it. Texas is going through it for sure. And I know a lot of other places are. And even with COVID, it's important that this topic that we picked today to discuss is discussed because it's how to advocate for your pregnancy, delivery, and postpartum health.
Right.
Why I wanted to do this is, and you may have seen, I did a discussion recently with Charles Johnson from For Cure for Moms about, and if you haven't seen that live discussion, it's about his story of his wife who died after a cesarean section. And it was a very good discussion, but I got a lot of questions about how to advocate for ourselves, not just as women of color, and we're definitely going to talk about that, but in general, how to advocate for yourself in your pregnancy, delivery, and postpartum care. So the first thing I wanted to talk about is the importance of knowing your medical and family history.
Very important.
It starts with something as basic as that. Why is that important?
Well, I mean, I think a lot of times people don't understand that there's some sort of hereditary, value to what may be going on with you or what you're predisposed to. And so I think that knowing your family history is really important. One thing, though, that I think is really interesting is health literacy, right? So, I know for people like me, and both of my parents are immigrants, right? And my grandparents' generation, they didn't have formal schooling. There's these stories that I hear about maybe illnesses that they had or ways that they died. And I'm like, well, it sounds like for example, it's my grandfather on my dad's side, I'm like, sounds like he probably had some sort of GI cancer because, of how they described him at the end. But there is no knowledge. And a lot of times there's no, they may not have gone to the doctor or things like that. So try to gather as much information as possible, because if one of your family members, especially your close family members, like your parents, your siblings, your grandparents may have had something, it may make you more likely to have it yourself.
And the other thing too, and I see this with my patients a lot, and we have a lot of, most of my patients are indigent and they come from other countries and they don't even know about their medical history. And it's not until we get paper records that we see some of the things. And I'm like, how could they not know this?
Oh yeah.
And I think it's a combination of I think it's both ways. The provider's not explaining enough.
Yeah.
That's probably the bigger of the two.
Oh yeah.
And the patient doesn't always ask, because I know patients don't always ask me.
Oh yeah.
And I'm sure you see that too.
Oh yeah.
So knowing exactly what happened in your medical history and keeping a log, keeping a journal, a notebook, what medications you've been on in the past, what procedures you've had, what surgery you've had. I've had a patient with the surgery scar from xiphoid, which is by your ribs down to pubic bone, didn't really know what happened. So how can we do better by that?
Well, it's kind of interesting you say that as well, because like one big thing is that, and it's like, sorry, mom, but I love to use personal examples.
Mm-hmm.
My mom like failed to tell my brother that he had a blood transfusion as a baby, right? So what was very interesting is that he, like, I was in the military, and so was my younger brother, and he got like his like blood testing for the military, and then I get what I'm assuming happened is that he had some sort of antibody testing which came back positive, right? Because he got blood transfusion in like the 80s, right?
Yeah, yeah.
And so he's like, you know, he's like, I don't know what's going on. They retested him. He was like, you know, he's not an IV drug user. He's not this. He's not that. He's like, I'm not aware of having any blood transfusions. He gets tested again. He has the same antibodies. And so he finally goes to my mom and is like, because they told him, ask your mom about this. And she's like, oh, yeah, you had a blood transfusion as a baby because you had surgery. And I remember, I think I was like in college or something like that, and I'm like, you didn't think that he needed to know he had a blood transfusion?
Yeah, and that happened with
like,
my mom. My mom has hepatitis C from a blood transfusion she got in childbirth with me because she hemorrhaged, and I didn't even know until she was much older and I was much older. It may have even been after medical school that I realized that that's what happened. I didn't know that she had such a traumatic delivery with me. So, you know, this is 2021. We have access to my chart. We have access to get our medical records. You know, and this is what I tell patients a lot, because I don't know what your patient population's like, but most of my, it's transient too. Like I may only see them for the delivery and never see them again. And this is what providers could do. If they had a significant event in their pregnancy or delivery or postpartum course, I will get them a copy of the records before they leave.
Yeah.
Because I don't know that I'll see them again, and the chances are that I won't. So, you know, we can do better as providers as well to make sure they understand how important it is that they remember and know exactly what happened to them, right?
Oh, yeah.
Yeah.
Oh, yeah. And I totally agree, because I have a similar population, large, like underinsured, uninsured, a lot of people who, you know, kind of different immigration status, things like that. And so, and yet we have a whole bunch of people who come from all different countries, and, you know, this is like their fourth baby, and they're like, I had a C-section. I think I was about this time. Why did you have a C? I have no idea. And then you're like, you know,
we're trying to put the pieces of the puzzle together.
Oh, yeah. Or like, my baby died, and you're like, well, what? Like, what happened? And it's really hard. So it's like, like, you know, trying to give people records or explaining to them what happens in a palatable way, because a lot of times, like, even one of the big things that I like to talk about is that even when we get translators, right, for whatever language, like I work in a community where we have a large Bengali population, a lot of Central Americans, you know, Caribbean, etc. And what I notice is that, you know, there is a health literacy gap, there's a literacy gap, right? And so we may be using, you know, ovulation and endometrium, and then that translator will translate ovulation and endometrium.
They still don't
know what that is.
They still don't know. Yes.
You don't know what you're talking about. So yes, you said it in Bengali, you said it in Spanish, you said it in whatever language.
But they still may not understand.
They don't understand it. So I feel like we have to do a better job of explaining, because I've had a couple patients where they've had something really crazy happen to them in the past with their medical, like with their medical history, and they were able to describe it to me to a point where I'm like, I know exactly what happened, and it was in their way of saying it, and it made a lot of sense.
Helps. Yeah. Just keep a journal, keep a medical journal, start writing everything down. I promise you'll never think you wrote down too much. You might think you didn't write down enough, if anything. So it's not going to hurt to keep that journal. The other thing that's important, especially in my patient population, it sounds like in yours, that's transitory and they come from all over to deliver, you need to plan for your care. And that means, you know, some of my patients live hours away. The closest place to them might be an urgent care that is not going to do anything with a pregnant patient. Oh, yeah. You know, you need to know where you can go in an emergency if you're pregnant. What is the closest hospital that has a labor and delivery unit? Because not all hospitals do. And urgent care definitely does not. Of course, you can go there in a dire circumstance, but you should, you know where to go in certain situations. You know, plan, you know, if something happens and I have to go in the middle of the night, who's going to take care of the kids? Even though things may seem okay, you never know when that's going to happen. Right. So having that plan in place is essential, right?
Oh yeah. And like what's really interesting for me is like, so when I was in the military, I was in more like I was stationed in more rural places, which was
Yeah,
definitely
yeah.
true. We had, you know, like we were the only LND for like a 60-mile radius. So and there were other
Mm-hmm.
hospitals around, but like
Right.
they didn't do
Mm-hmm.
anything with obstetric patients, or they didn't do anything
Mm-hmm.
with, you know, pregnant
Mm-hmm.
patients at all. What's interesting is that here in New York City, yes, we have tons of hospitals with labor and delivery, but like especially even some of my patients, they're like, you know, they're without homes, like so
Yeah.
they're in shelters and things like that. And then the way in which a lot of these systems work, which
Mm-hmm.
is really unfortunate, is that they move people from shelter to shelter,
Mm-hmm.
and it could be like, and yes, New York City geographically is not super far away,
Mm-hmm.
like from, you know, things are geographically not that close, but in terms of public transportation
Yes.
and actually getting to where you need to go to, it feels like
It could be
worlds
hard.
away. And
Mm-hmm.
so you can start your care with me in the Bronx and then end up the, you know, the housing department decides to send you to a shelter in Brooklyn, and it's
Mm-hmm.
like
Yep.
knowing kind of what's around there. And
Mm-hmm.
if you were, and like we have different hospital systems, a lot of times if you're within the same hospital system, that makes it a little bit
Mm-hmm.
easier, you know, in
Mm-hmm.
terms of getting your records, things like that.
Mm-hmm.
But like, you know, really, like if there's at any point you're able to know and plan beforehand, you know,
Mm-hmm.
something's changing or whatever, like you should try to have that conversation
Yeah.
with the providers you're seeing.
Good. Yeah, and I agree. You got to know where to go in certain situations,
Mm-hmm.
because there's 24-hour emergency rooms on every corner now, but they don't all do. They're
Oh
not going to be
yeah,
able
they
to
don't
right
all
away.
do what we do.
Yeah, they're going to call right away and try to get you out there as quick as possible. So, you know, it's just important to know where to go when you're pregnant and in the postpartum period. The next thing I want to talk about is researching your healthcare provider.
Yeah.
And there's so many things you can do.
Yeah.
How would you advise someone to research their obstetrical care provider? What are some of the tips that you have?
And I feel very, very passionately about this
Mm-hmm.
because I do think that it can be hard sometimes to
Yes.
know who to trust and how to trust and things like that. And there's so much information, right?
Mm-hmm.
So, like, first off, like, you know, if you're going by where you live and you want someplace, you know, kind of reasonable and close, you can always ask people around you if
Mm-hmm.
they've had positive experiences with different people and whatnot. That's always a good place to start, right? And then, like, if not, you can always, you know, just look and see what practices are around.
Mm-hmm.
And, you know, one thing that you should definitely look at is, like, if they're board certified or not, right?
Yes.
And, like, because that's super
Mm-hmm.
important. And,
Mm-hmm.
like, not everyone is.
Mm-hmm.
And it's not to say that like people are necessarily good, bad, what indifferent, but you have to understand that, especially and depending on how long they're out in
Mm-hmm.
practice they are. Because okay, if you just got out of residency, you're not going to be board certified. Like that's
Right.
not how it
Right.
works. It takes a few years. But if somebody's out for 10, 15,
Mm-hmm.
20 years and they're not board certified, it's
Mm-hmm.
something to think about. And that's something that I have seen in multiple different communities.
Mm-hmm.
And you have to understand that with board certification, it kind of holds us accountable to a certain extent,
Mm-hmm.
right? Like we have to read a certain amount of articles per year
Yeah. Mm-hmm.
in order to stay current, to, you know, to maintain
Stay.
that
Yeah. Mm-hmm.
certification. Like additionally, like we, you know, if you are doing things that are wildly out of
Mm-hmm.
line for like the, you know, ABOG, American Board of Obstetrics and Gynecology, like that's frowned upon and people can actually hold you accountable. They
Mm-hmm.
can write to the board and
Mm-hmm.
et cetera, et cetera. So there's a certain level of accountability with that I think is
Mm-hmm.
important. And like one thing that I thought was really shocking was like the amount of people who are not board certified,
Mm-hmm.
like, you know, because like I had been in circles where pretty much everyone is board certified. And then like, and then the thing is that, and then you see how
Yeah.
wildly different the
Yep.
practices can be. So I
Mm-hmm.
definitely think that's a really important thing to look at. Another thing is like, I always say hit or miss with reviews
Yeah.
because like, honestly, I always tell people like this, whenever, like even when you're looking at restaurant reviews or whatever,
Mm-hmm.
Does anybody ever write a review for something that's just okay? Like, if it was just, like, it wasn't bad, it wasn't good, like, I got what I needed and it was all right, like, do you leave a review? Do people normally leave reviews? Usually not. It's usually if they love something or they absolutely hated something. So it's like, and the thing is that what someone else loves, you may hate, and what you hate, someone else may love. So it's like, someone may say, like, oh, this person like sat next to me and like did this and did that, and you're like, and that may just not be your vibe. You may want somebody who's a little bit more, you know, like someone who like, you know, maybe a little rough around the edges, but you're like, I just want to be told something. So like with reviews, it's hit or miss. But one thing that I will say though is that in reviews, and like I've even seen reviews of, you know, different places that I've been a patient to or whatnot, like if there's like some big red flag thing in the reviews like that, you're just like, everybody's kind of saying this and like this is like a no-go for me, then don't do it, right? Also too is like when you're picking a provider, like it depends. Like, so I know there's like this whole talk about like cultural competency and like if people are like from a similar background than you, things like that, you know, sometimes you don't have that option. Like, honestly, like, I like to kind of talk to that because I feel like in places like New York City where I am, like, there are tons of providers, right? And like, it's a matter of like insurance and things like that, which may limit you. But like most times you can probably find someone that is close enough or like similar background as you, right? But like when I was upstate New York, like when I was stationed upstate New York, I was for a period of time the only female OBGYN, right?
Wow.
For 60 miles. Like,
wow.
And I was in the military, so like most people who did not have any sort of military affiliation could not see a female OBGYN, which is like super rare, I think, like nowadays. But there are parts of this country where that's the case. And so like if you were someone who was like, I don't want to see someone who's male, then you're gonna have a problem. And so it's more so like, you know, you have to kind of find whoever's gonna fit most to you. And like honestly, you can audition them too. Like just because you see someone doesn't mean you're stuck with them forever.
Right. So I think that goes along with there was a thing about treating that first couple of prenatal visits like an interview. That may also going along that same lines, you need to establish care early. Now, with COVID, and we could say this, not everybody's seeing patients really early. They might wait till 8 to 10 weeks, and that's fine. If you're otherwise uncomplicated, that's fine because they got to do what they got to do because of the COVID thing that's going on and has been forever. So they might, or that first visit might be a telemed visit. That's happening as well in obstetrics. So all of that's fine. Whereas, you know, pre-COVID, that first positive pregnancy test, people were getting in to be seen. That's not necessarily happening anymore. So just keep that in mind. But you can ask those hard questions first off. See if you mesh. And the importance of that is figuring it out early is if you decide later on, you may not be able to find another provider to take you because some providers have cutoffs that they won't take anybody past 28 weeks. They won't take anybody past 30 weeks. So I've seen that before where someone wanted to change providers at 28, 29, 30 weeks and they could not find anybody to accept them.
Oh yes, I've seen
that. So
talk
about that. Yeah.
So like, and that's hugely important because part of it too is that it's more so people want to be able to get to know you, get to know your medical information, and like, you know, kind of really establish care and, you know, come up with treatment plans before you're like delivering a baby right then and there. So it's like, you know, if you're like 34 weeks and you show up and you have like a whole bunch of stuff going on and they're like, oh my God, I think we have to have your baby like tomorrow, it's kind of a disaster in a lot of senses. And even if that provider is like super like amazing and like really, really, you know, and you gel with them and they're brilliant, it's still, you're still not getting the best of them.
It's hard.
You're still not getting the best of them. And I definitely believe in like interviewing your provider. You are not stuck. And then also what you said too, which I think is really interesting, is, you know, asking questions, putting out your concerns. And quite frankly, like I've actually recommended this to a lot of people, is like ask, like, you know, especially if you're a person of color, or even if you're not, just like, but certain things are really important to you.
Yeah.
Like, you can ask, like, what are your thoughts on the Black maternal health crisis?
Mm-hmm. Mm-hmm.
And whatever is said is very, very indicative of
Mm-hmm.
their thoughts, and then you can kind of use that to your
Mm-hmm.
advantage, whether you appreciate what they've said or even you get an answer that maybe you weren't expecting, which
Yeah.
is positive or negative, and you can use that to your benefit to figure out if you want to stay with that provider or not.
Mm-hmm. Yeah, so to pick the top few things that are most important to you, hash them out early on, because you can't get everything answered. It's not going to happen. There's not enough hours in the
Yep.
day to ask that provider everything, but at least pick some questions that will help you to decide if that provider's is someone that you can work with.
Yeah.
Right? So like I said, you can't come with a list of 20 questions. It's not going to happen. Pick the top
Exactly.
5.
So,
Pick
like,
the
for
top 5. Yeah.
example, exactly. One big thing that I really think is really important too is that, like, I tend to see a lot of patients, especially because I actually have my practice has a large midwifery group
Mm-hmm.
that that we work in conjunction with. And so what's interesting is, like, people who've had C-sections before and may want to have a trial of labor after, right? And I really actually appreciate when people bring that topic up
Yes.
first visit,
Yes.
within the first couple visits, and we
Mhm.
actually have a conversation.
Yes.
Like, because I feel like it's so important, or like, or another thing that I've been really appreciative of a lot of patients that are doing lately that I've noticed is that they'll talk about something about their last delivery that they felt to be traumatic, like, and there are a lot of things that happen because it's a crazy situation, but they bring it up early.
Yes.
And I
Yeah.
literally say, I'm noting this in your chart, like, so that, and it's in your problem list. So that's like the list that everybody sees. And I'm like, I will put down that, you're concerned about, the epidural, or you're concerned about this, or you're concerned about that, because last time this is what happened. Because, like, and let's put it out on the table early, and let's talk about it. And if that means that you need an anesthesiology consult, like, earlier, we'll do that, just because we shouldn't just limit people to, like, okay, you get what you get and whatever, and you deal with it. And like, and I'm in a group where there's 10 docs, like tons of midwives, tons of anesthesiologists. Like, you're going to get different people, but like, if certain things are made mention of, like, kind of in prenatal care, we usually talk about it when you come in. And make a plan for you.
That's very important. What is the provider's experience with trauma-informed care? What is their experience if you are a gender nonconforming or trans gender individual? I mean, those are things that you want to find out earlier on. And how they answer is going to tell you a lot, actually.
Exactly.
I mean, just like what Dr. Irobunda said, if you've had a previous C-section and a VBAC or attempting a TOLAC, trial of labor after cesarean, is very important to you. That has got to be brought up early, because the provider and or the hospital may not do it.
Yeah.
And then in which case you need to switch to somebody who can. So there are certain things that are important to tease out earlier on in the event that you might need to try to find another provider to suit your needs.
Exactly.
So it's really important. So let's talk a little bit about taking notes, asking for follow-up questions. So things can happen in one obstetrical visit. Maybe there's a lot going on. You took some notes and then you realize that I have other questions. One thing I like to do is we know, when you're talking to somebody and I just unloaded a dump truck of information on this patient. I know I did, because I was talking about for 20 minutes straight.
Yeah.
The patient probably received 30 to 50%, not because they can't receive it, but it was a lot.
No one.
It's hard. It's hard. And I'll say, you know what? Listen, when you get home, if you want me to talk to your support person, since now it's COVID, there's not a lot of support people in the visits sometimes. If you have other questions, call this number, so that they know when they get home, if they had other questions, this is what they do, so that they know that this wasn't it. They got what they got, and that's it. There's got to be provisions in place so that they can call and get more information or ask questions as follow-up. So taking notes is important at your visit, especially if you're receiving any kind of information that's important, not just the run-of-the-mill stuff, but something that's different. You got diagnosed with diabetes, you got diagnosed with preeclampsia. Well, let's start taking some notes. Do you
Yep.
get offended when a patient pulls out a pen and paper or starts?
Absolutely not. You shouldn't.
No, you shouldn't.
You really
You shouldn't.
shouldn't.
And along the same lines, sometimes I will say, and especially in COVID, but even before then, if it's just them in the room and I'm giving them information about an ultrasound, I'll say before I even start, do you want to call somebody at home? They can FaceTime and listen as I'm counseling you.
Yep.
You know, there's nothing wrong with that. So there are ways, and if a provider has a problem doing that, they shouldn't. They shouldn't. You should be able to do that, especially now when if you go to an ultrasound, you're not allowed a support person sometimes, depending on how bad COVID is. So we should be able to offer that to you so that somebody else can listen. I did that just today. And it's not a hard thing to do. Everybody deserves a support person, right?
It's true. And I mean, and I feel like also in general, like, just given people are working, people are doing lots of different things. People, like, for example, I have patients even pre-COVID who they're like in the military where people are deployed to different places. They're, their spouses in training, things like that. And so just having people present in there and may be able to ask questions, that's totally normal and should be allowed.
And I think one thing that COVID has, a little bit of a silver lining, if you can find a silver lining, is it's really kind of helped to refine a little bit telemedicine.
Yes.
Which I think is great. And a lot of providers who weren't used to doing what we just spoke of and talking to that person by the phone or FaceTime, we've had to learn to get used to it. And it's important to do that because, it may be another year or even longer that we're still going to have to do it. So just suck it up and do it and make it part of your counseling whenever the patient doesn't have somebody there with them.
Exactly.
Now, the next thing I want to talk about is something that is, I get asked a lot. I'm pregnant and I don't agree with what's being recommended to me by my provider. And can I get a second opinion? If the answer is yes, how do I go about that? What do you have to say about that?
So I definitely believe that you can get a second opinion. I always think that's an option, like any way you look at it, right? And so it kind of depends on where you are and your ability, like kind of like the different practices, different things around it, like, because I've seen this go a variety of different ways depending on where you are and whatnot, right? Here in New York City, it tends to be easy to actually go to like, you can actually, maybe find a different provider in a different hospital or different setting and get a second opinion. I've seen even people do it pretty late into pregnancy. But that's not always the case everywhere you go, right? And so like sometimes, like when I was in rural upstate New York, where it's like there's like 3 practices, some of them are solo practitioners. And some of them have like different they're like, I don't take anybody after 28 weeks, period. I've seen people do it where they've asked like people like yourself, who's a high risk OB doctor, like an MFM, to like weigh in terms of like a second opinion in terms of that kind of stuff. And there we were doing telemedicine, so it kind of worked out that way. I've seen people do it where they've gone, if it's a practice with multiple different providers, they've gone to, seen a different provider in the practice, or I've seen it where they've gone to multiple different providers in the practice to see what other people thought and kind of took it from there. There's a lot of different ways that it can be done. Like some of it can be like, you can try different people within the same group and see if there's any, and see what their opinions are from there. You can try with a different group altogether, or you can try, if it's an OB thing, going to the high risk OB doctor and requesting a second opinion from there. So I've seen it happen like a whole bunch of different ways, but you can definitely do that. And I think that if you really feel like very against something, it's reasonable to do that.
I think a lot of this comes from if a provider makes a recommendation and they just expect the patient to take it.
Yep.
It can go a long way if you say, I'm making this recommendation because.
Oh, yes. Oh,
instead of just saying, I'm making this recommendation because I'm the OBGYN. No. Explain why. Why is your, and if you just start out doing that from the top, that actually helps prevent a lot of miscommunication.
It really does.
It does. If you just explain, because of the data we have on X, Y, and Z, Uncontrolled diabetics are typically delivered at around 38 weeks because of what we know. I'm just giving that an example. I'm not saying that across the board, or we do chronic hypertensive here, and this is what the data show, and this is, but I will say this also, even what the data show or what our recommendations are, there's always going to be a little bit of a window there. You're going to have a upper limit of normal, a lower limit of normal, and then there's a little bit of gray in between. And then you could talk about that specific individual and if they fall in that gray area.
Yeah.
If you can, there's always going to be a little bit of wiggle room, unless it's an urgent situation, of course, but there's always a little bit of wiggle room. So just go ahead.
And one big thing that I have to say about that too is that like, and I kind of gets into the discussion of paternalism.
Yes.
Which I feel like very, 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 very strongly about, because I feel like it's wielded a lot in obstetrics, right?
Yes, it is. No, it is.
Like a lot. And it'll be like, and it may not necessarily be like, it's like, you have whatever choice you have, but you know, your baby could die. Like,
okay,
I'm gonna stop.
I have drilled into I'm in academic medicine, and I tell them all the time, the minute you go with the die card, you're going to lose your patient. You're going to lose your patient.
Done.
First of all, it's not necessarily true.
Right.
Now, could they have a bad outcome? Yes, but it's not always going to be death. But as soon as you start, it's just going to make them think that you're saying they're a bad person or a bad you cannot use the die card.
And it drives me nuts.
It's fear. It causes fear. It causes shame. It causes, them just to completely block you out, and you're going to lose them right then, right? I mean, I've seen it so many times. We've got to stop doing that. It's not fair.
And it's so unfair, and it's like, and it doesn't leave any wiggle room. Like, whereas, like, for example, right? It's like, okay, like you want somebody, you think that this is like, probably what they should be doing, right?
Yeah.
And my thing is that if you can't find any other words in your vocabulary to describe what's going on and the reason why you think it's a good idea, aside from your baby could die,
he's gonna die.
like, I think it's really sad. Like, we did all go through training and
yes.
all that stuff.
Now, has there been, and I will say there have been times where that it was a very real possibility, and I've had to use that argument, but that's the exception, not the rule.
Yeah, that's not the rule.
It's not the rule, and most of the time, majority of the time, there's always room for compromise. There's always room for compromise, and if you have a provider that doesn't have compromise on the brain, it's a problem. It's a problem. And so I get it. And just what you said, the whole paternalism and the not willing to compromise, and and we're the ones that are making the decisions, is why we're where we're at in obstetrics at this point right now.
Oh yeah.
With a lot of distrust.
Exactly what it is.
Yeah, a lot of distrust and feeling like they need to.
Yeah, because people are not explaining things. And like, so, and that's the thing that I get like the most frustrated about, where it's like, like sometimes I even start off with like, so tell me like what you know about what's going on right now. So tell me like, exactly like what is your
understanding? What is your understanding of what's going on?
Exactly. Because the thing about it is that like, I feel like sometimes when I step into these situations where like the patient wants to go home, this patient's going to sign out, blah, blah, blah. I feel like, I'm like, let's back it up and let's go with like, tell me what you understand about what's going on right now. And then we take it from there. And my thing is that, you know what, like, if you feel like you like are confident in how the patient is understanding the situation, and you guys have had a conversation and the patient still says, you know what, like, I still don't want to do this, you have to respect that. You have to understand that, because you have to understand that it's a mutual respect thing, right? And that we also have to understand that our, like moral codes and the way that we operate are very different, and that's okay. And you know what, if you think something is, really not like, like something you really wouldn't do, you can, you offer different options. Or like most times when I see it, it's usually because there is something socially going on with the patient or the patient's family or something like that, where they can't stay or they don't want to do something. And it's and like, if you actually dig deep, you figure that out. And like, you know what? Yes. So the recommendation says, okay, it's supposed to be strictly like this period. But if the patient's telling you, listen, like, I have 4 kids at home and I have nobody to watch them, and like CBS is going to take my kids, like if I don't go back, then you know what I mean? And they're like, I can't really, like, I don't have the bandwidth to like figure this out. You need to help them figure that out.
But we also have to understand too, that doesn't make them a bad person or a bad parent.
Oh yes.
we have to understand that it may not be, and it's hard because I have patients that have a lot of social issues,
Oh yeah.
and I know with what's going on in the pregnancy that the patient needs to be in the hospital. I know
Oh
that.
yeah. Oh
But I
yeah.
also know, like you said, they have childcare issues. And so what I say is like, look, this is the recommendation. I'll say, this is what I'm putting on your chart, what the
Yep.
recommendation is. I'm going to put why you're choosing to leave.
Yep.
I'm going to put that there too. But once you go home, this is what you need to look out for.
Yep. Yep.
Because I mean, it's not fair of us to, hold them hostage or, guilt them or make them feel worse about their situation, because majority of them already do. They
Oh
do
yes.
feel bad about leaving. And, we just have to understand that it's not easy. It's not easy. I was in the hospital for 2 months, but I didn't have other kids at home. I had a pit bull at home. That was it. And,
Yeah.
that was hard on me. I couldn't imagine having other
Yeah.
kids at home that I couldn't see for 2 months. So we have to look at the big picture
Oh
and
yeah.
make sure our recommendation is known, understand their side of the story, and know that even though they went against medical advice and went home, we can still equip them with certain things to look out for. And this is what you
Yes.
need to come back for.
Yes,
And
because like
that helps. Yeah.
there have definitely been times where it's like I've been like, oh my God, like
Mm-hmm.
I can't believe you're going home.
Mm-hmm. I know, me
But
too.
like,
And I
you
will
take a
lose
deep breath.
sleep. I lose sleep. I will lose sleep over
Exactly.
this. I
You
do.
take a deep breath and you're just
Mm-hmm.
like, all right, well, this is what we have to do. And
Yep.
then, yeah, like I've had times when I've had a patient come in every single day
Mm-hmm.
for whatever the case may be,
Yep.
because I was like, all right, like since you opted, and then I mean, and every day we will revisit the topic of like,
Yep.
I really
Yep.
think you should be here,
Yep.
and they're like, I'm still not staying, and that's okay, but like we're gonna revisit it every time. But you know what? Then you also build a partnership with them, because at the end of
Mm-hmm.
the day, like sometimes I've had it where it's like they've been able to try to figure something out, or
Mm-hmm.
whatever the issue is, they're able to figure something out in order for them to be able to do whatever therapy or
Mm-hmm.
whatever you're recommending. So I
Mm-hmm.
think when you show good faith, like you'll
Yeah.
get good faith
Yeah.
back.
Yeah. 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 And along the same line too, it is okay. I think it's getting better. But I do remember the time when patients just didn't, and I've heard about the time where they just didn't feel like they could question their provider.
Oh
The
yeah.
provider is the doctor. They're the ones with all the accolades and all the training, and I can't question. Well, that's simply not true. It's not true.
Hmm.
It
It's
wasn't
not.
true then. It's not true now. You can
Yep.
ask questions. It's your health. It's your health. It's your body. You can ask questions about anything you want. It doesn't matter how many years we trained.
Yep.
Or, you can ask questions. So I just want to put it out there. You can ask questions about anything, and people should not get offended. They should
Yep.
not feel like you don't trust them. They should not feel like you're questioning them. Asking a question does not mean you're questioning them. It's asking a question.
Yep.
Simple.
Exactly.
It's simple. Because we
Exactly.
know, if you or I went to go have something done in the hospital, we'd be asking all kinds of questions.
Oh yeah. And it's
Right?
like whenever I've had anything done, it's like,
Yes.
and it'll be like little, big, small, where's like, how am I supposed to park this car? Like, where am I supposed to park? To like, what would you do if this was somebody who, like, this was your, family member or whatever, to like,
Yeah.
what is the percentage of it? I'm asking all kinds of
Yes.
craziness.
Yes. Yeah. Yeah. So any provider that's listening, they can ask questions. It's their right. They can ask questions, and you shouldn't
Hmm.
get offended by it. You shouldn't.
Yeah.
So that's important. I want to put that out there too. So one other thing is, we talk about so much about the pregnancy and the delivery and getting that child home, and then it's getting better, but it's not quite where it should be about the postpartum course. We
Oh yes.
still need to be vigilant in the postpartum period. You can still ask questions. Yes, you just went through childbirth and you may not feel optimal, but you should not feel sick. You should not feel terrible. You still have to speak up for yourself and advocate for yourself in the postpartum period.
You
What
sure
can we
do.
do to better do that in the postpartum period? Because, and I've done talks here about maternal mortality, a lot of them occur in the postpartum period and even up to a year. So it is still, the postpartum period is just as important as the pregnancy. So
It
what
sure
can we
is.
do to advocate for ourselves in the postpartum period?
So I definitely feel like, I'm a big fan of taking notes in your phone,
Yeah.
right?
Yeah.
And like, especially in that postpartum period, you have a new baby, like a lot of things are changing, not only in your body, but in your life, right? And you're sleep deprived and you have a lot going on. And I feel like oftentimes with postpartum visits, whatever that may mean for you, if that's like a routine visit after a vaginal delivery, or
Yeah.
like even just like an appointment after a C-section, people are just really stressed. So you got the car seat, you got this, you got that, you know, and I feel like the stroller, this and that. And especially for our first time parents, it may be even more challenging because you're like not used to juggling and you're now at this appointment for you, not the baby. And you are just like, I'm just trying to get through the day. And you may have had things that were on your mind in the middle of the night when you're out feeding this baby that you now have forgotten to ask, right? So that's why I think taking notes in your phone or someplace handy, usually your phone because you probably won't misplace that, is really important because, hey, if you realize at some point you're not feeling like yourself, you're feeling down, you're feeling depressed, or if you notice you're like, hey, I feel like I'm bleeding kind of heavily and it's been happening all the time, but as many of us who are just trucking through life, you know, when you're coming to your appointment, you're just trying to get through it because it's another thing that you need to check off the list. And then when I ask you, oh, how's everything going? How's your bleeding? Oh, yeah, fine. Okay, let's go, right? You may forget to talk about these things. And when you do that, that was a missed opportunity.
Yeah.
Additionally, I know that for any place that I've worked, in most places, the same numbers that you used for any sort of like urgent or emergent issue is still, it doesn't, I always tell people, we don't cut it off after delivery. We don't say, oh, we know we don't block your number. We don't do anything like that. So if there's something urgently going on and you need to know something, you can always call those numbers and we can direct you to the right place. And I've definitely had people who've called in the middle of the night and they're going through something that they need help for. And I was able to get them to where they needed to be. Or in some places I've worked, it's been labor and delivery. Everybody calls there and people have called there and have gotten what they needed.
The one other resource that I think is great, I actually have a highlight on it. It's called the CDC Hear Her campaign. And if you Google CDC Hear Her campaign, they'll pull up urgent maternal warning signs. They talk about things that are warning signs that could be significant that you need to address. They go into a detailed explanation. There's about, 12 to 15 of them that you can look at. It's a great resource. Again, you can go to my highlight, CDC Hear Her, and look at what the CDC put together because it's beautiful. Allison Felix.
It is really nice.
It is nice. Some of the other athletes and celebrities have come together to help share their stories as well as women of color who went through issues either in pregnancy or postpartum. But again, this can apply to anyone. So going there, it's a great resource. And I urge you to go there about things to look at, especially in the postpartum period, because we're not out of the woods once we deliver.
Definitely not.
We're not.
And that's a huge thing that I really think needs to be drilled home because I've just seen so many postpartum patients with like real, just like rough things going on, and some of which I feel like went on for longer than they needed to have. And so it's just so important, so important for us to not forget that person who just had a baby.
I agree.
We can't forget.
I'll tell my own story. I had an emergent C-section, hemorrhage, blood transfusions, with the twins. My wound was open. And because the day I got discharged from the hospital, the very next day, I was making an hour drive to the NICU every day. I didn't even realize it. I didn't realize it because I was worried about my twins at home. I had an open wound that was leaking. Don't ask me how I didn't know that. I wasn't paying attention to my body. I wasn't paying attention to my body, and I let it go too long. And so I know I'm an OBGYN MFM. If I can neglect myself, I know other people are doing that. We have to start realizing that we're just as important postpartum as we were during the pregnancy, if not more.
Oh, yes.
So it's okay to demand and ask for care and adequate care in the postpartum period as well. So
100%.
Just remind that's it's just as important. It's just as important. We deserve it.
100%.
We can't just go home and fall apart. It's not gonna be good for your babies or baby or anybody else.
Exactly. And one big thing that I always like to drill down to my postpartum patients is that So we are always like baby first, and I'm like, you know, and I'm back here. I'm telling you, even when the baby's on the outside, inside, outside, you have to take care of you, because you are no good to that
Yeah.
child if you're
If
not
you're not.
okay. You're
It's
not.
true. It's true.
You're not.
Very true. Okay, I want to switch gears a little bit, and this goes back along to what I had discussion I had with Charles. And again, if you guys haven't heard this discussion, go back and look at it. He lost his wife after a routine elective cesarean section. She had an intraoperative injury, bled over 10 hours. As soon as they took her back to the OR, multiple hours later, as soon as they started operating on her, she passed away. And it's awful. It was awful, and it should not have happened.
Yep.
So one of the things he was talking about is how he kept talking and please, and he was told that his wife was not a priority. I mean, clearly multiple things happened that should not have happened. And now that's an acute situation. In an acute situation, which I think mostly would be in the labor delivery process or post-operative process if you've had a cesarean, when things can happen very quickly, and there's not a whole lot of time for a long discussion. And, you know, as much as we try, and you've been in those situations too, we can't sit down and have a 10, 20-minute counseling sessions for everything that happens. We just can't. But I just will say this. If you start from the very beginning, during the whole labor process, explaining what's going on, once you get into that urgent situation, the rapport has been set, the trust is there, you can say, listen, you got to go to the OR. This is what's going on. The patient's going to say, get me there. Because you worked on it for all those hours leading up. And it doesn't mean you had to have them for the pregnancy care, because the patients I deliver, I do not do their prenatal care. But what I do is I start from the moment I walk in the room through the course of the labor. Every time I see them, I start, you know, I build and build and build and build and build so that they know. And I talk about the what ifs if I'm worried about stuff. So there's ways that we can do this. But the questions I got after hearing Charles's story about he was just not listened to, he was not respected, his wife was not a priority, and she bled to death. How can they advocate, even as a support person or as the patient? How can we advocate for ourselves in those more acute situations? What can we do?
So I always say, and this is something that on kind of the clinician end and the caregiver's end, we should be working on in terms of like how we form our teams and what our teams how our teams should be communicating amongst ourselves and to our patients and support people. But I would say if you're the support person, you know, ask for clarification. And we on our end should have somebody who's a member of the team who should be able to be like, hey, let me break it down for you really quickly. And we definitely, I feel like where I am, we do that a lot, where it'll be like, okay, like if we're planning to do something like more emergent or something's going on, like for example, because I work with midwives, so like what will happen is that, let's say, usually as an OB, I actually meet all my patients when I come on shift and just I'm like, hey, I'm here just in case of whatever, like, and I'll you know, if everything looks fine, this is not for now, this is just in case of any sort of issue, you may see me again. So they already have seen my face, right? So it's not like here's this foreign lady running in the room and saying, I'm going to do surgery on you now. So like there's that part. Then like, let's say there's some issue where, you know, we're concerned about the both patients, either their issues. And I come in, like usually if there's like a midwife and it's me, then like, you know, if I'm saying, okay, we need to do this and we're kind of like running to do something else, at least maybe the midwife can talk to, you know, can clarify details of that. The nursing staff can clarify details of that. But like somebody has to take a second out to like really debrief and say, you know, hey, be honest. Like, don't say, I can't talk to you right now. You're not a priority. Like, we got to do this now. Like, you can even make it part of your vocabulary to be like, hey, this is really acute. We're really concerned about X, Y, and Z. We definitely want to tell you more, you know, about more of what we're doing. I'm actually going to send somebody to talk to you right now. But this is the biggest concern that we have. Because honestly, you can't do something if someone doesn't know and doesn't really want it done. Like, and it keeps, you know, and it's something we have to get better at communicating with. Because like just saying, you need to get this done because either you're going to die or I'm you know, like I told you so is like not going to work.
It's not going to work. Yeah. I mean, and I think in a situation such that Charles described, it was so, I don't even know the right words to put it. I don't know that I think he did everything he could have done in his power.
Yep.
And unfortunately, that happens to women
It
of color
does.
in this country. And well, it happens to all women, but disproportionately, obviously, to women of color. We've talked about this. I know I have, and I know you have.
Yeah.
And, you know, I wish I had a magic line to say,
Oh yeah.
to
I
tell
wish
you
I
what to
did.
say. I
Because
just don't, yeah, I don't know.
one of the biggest issues that I have, and it's something, and again, right? There are things that we can do as patients, right? Because I'm going to take both roles, because I'm a patient and,
Yeah.
a provider. There's things that we can do as patients to try really hard. And I've like heard it, like as a provider, patient support people and things like that, advocating for them. But I also see kind of on the flip side, how sometimes that's received.
Yeah.
And I try to take time out with my team when I, like, people may be like, oh, like, and it's everywhere. And I've worked in so many different types of situations, so many different types of patients and things like that. And I think that we have to sometimes take a breath and be like, what is this support person trying to do?
Yeah.
99.9% of the time, they're trying to make sure that whoever they're there to support is healthy and safe and, is being taken care of. And we have to make that
it comes out of
first.
fear, and it comes out of insecurity. And if we're talking about someone that you can't just say, oh, they're being difficult. We got to stop doing that too.
We have to stop that.
We have to stop.
And
whether it's the patient or, if I was scared, I'd be difficult too.
Yeah, like,
and I
what
have
are
been
you
difficult.
doing? Exactly.
As an advocate for my friends, and I've been in a few situations where I was difficult. Now, I'm an OBGYN and I have the medical way, the terminology, and the average person doesn't. What I think in those situations that are acute, you say, first of all, it shouldn't be the nurse relaying all the information. You ask to speak to the doctor. When is the doctor coming in? I want a time frame. If it's if you're at a teaching hospital, it's just the residents. Where's your faculty? I want to speak to the faculty. Yeah. There's always a chain of command that you could go up to ask to say, and you say, I want to know how long, I'm setting my timer, how long before they come into the room?
Yep.
I want to know. Because, if it's an urgent situation and that things are going downhill for your loved one, because a lot of times they're not going to be able to advocate for themselves when it gets to that severe of a situation. And I'll give an example. Good friends of ours, there are two situations in the last pregnancy that I intervened when they were being dismissed, and they're a couple of, a Black couple. And I told the dad after the baby was delivered, I told him what to say. Now, I knew what to say, but he had to, and he's not that type of person. He didn't want to be difficult or be perceived that way. But I said, but listen, it's your child, and this is what you need to say. You'll get some action, and sometimes you do. It's okay to be difficult. Whatever, to get some action.
And that's something that we actually have to normalize, and that's something that I really want to make sure that I say as a Black physician, as a Black woman, is that there's this whole angry Black woman, angry Black person, and, difficult and stuff like that. And sometimes you just have to be, because guess what? We are being, and it doesn't matter my education, I'm still at higher risk than you to
5.2 times higher risk than me.
Yep.
For an adverse pregnancy outcome and dying in childbirth.
Yep. And that's just, and we both went to med school, we
both went to med school. We have the same education.
Exactly.
And that's just based on the color of our skin. And it has nothing to do with anything else. And that's the reality of this country. And we have to, and I hate the stereotype of the angry Black man or woman. Unfortunately, it's there. And sometimes, and I told my friend, I said, you're just going to have to do it. This is what you need to say. Now, not everybody has someone like myself or Dr. Irobunda on the line to counsel them. But listen, you got to advocate for your, ask for the next chain of command. Ask them for a time. I'm going to set my watch and I want them in this room in 10 minutes.
And it's so crazy because I was actually just having this conversation that I was using this as an instructional piece to some of my students. So I was actually talking about a situation with my younger sister, right? And she had an unwitnessed single event, and in her apartment, she lives by herself. She woke up on the floor and she was pretty sure she hit her head, right? She goes to the hospital, and it's a teaching hospital, right? So she goes to the hospital, and she had been doing crazy, like working out, whatever. So that's probably, she probably got behind on her electrolytes or whatever. Fine. She goes there and they keep her overnight and whatnot. And you know what they failed to do? A CT scan of her head.
Okay.
Which I'm like, how? Like, what?
Yeah.
Like,
she unwitnessed. Yeah.
Yeah. And I'm like, don't you guys, I feel like you CT everybody. Like, why did you CT her? So I'm talking to her the next day and she's like, yeah, they're getting ready to discharge me. She's talking about how she's having, like, she can't have the lights. Like, she's like basically putting like a blanket over her head because the lights are really bothering her and she has a splitting headache. And I'm like, she might have a concussion and they haven't even scanned her head and they're telling her they're sending her home. And so, and she was just like, I'm just going to get ready. I don't even know how I'm going to get home. I don't feel well. Right.
Yeah.
Like, and I was like, oh, no. And then my first thing is like, what's the, give me all the information, call your nurse in, this, that, and whatever. And then I had to talk to, the resident and then the attending physician to be like, what is going on? Why haven't you scanned your head? Like, what's going on? But the issue that I had with that is the fact that I had to do that. The fact that I had to do that. And the fact that when I also called, something that I thought was really disgusting is when I called and spoke to the resident first, the way how this resident like answered the phone and first started talking to me before she realized,
with a chip on her shoulder, right?
Exactly. Yeah. Before she realized that I was a physician and I was an attending physician at this point. And then all of a sudden it was like,
flipped. Yeah.
And I'm like, wow, wow, because this was, in the Bronx, whatever, and people assume.
Yeah. And not only that, but most of they're going through this and they don't have a sister or a daughter that has a medical background. Can you just imagine?
That's literally what I said. I was like, this is awful. The fact that like, if this was, if this was the person, if my sister was someone who didn't have anybody medical in their lives, she could have gone home with a concussion
or a bleed or a small bleed.
Yeah, small bleed, anything.
Yeah, anything. Yeah.
And how would that have ended?
Yes, exactly. I mean, I know, and I've been in those situations. I actually diagnosed my friend with preeclampsia from the jungle in Nicaragua because they sent a 36-week pregnant patient with a headache and high blood pressure to see neurology. And I was like, no. I got off a canoe in Nicaragua, answered the phone, and said, this is what you need to do. So it happens.
Oh, yeah.
The last question, we only have a few minutes. I just want to end with this question. And we see this a lot on social media, that as a pregnant woman of color, that you, or a pregnant person of color, you need to seek a provider that looks like you in order to get quality care. And I'm not saying not to do that, but it's not always possible. And I think you touched on that earlier.
Yeah.
What are your thoughts on that? Is it necessary to do that to get quality care, or can we, if it's, there's not a person that's available, what are the alternatives that we have? If you are a Black woman in this country that's pregnant, a brown woman in this country, or a patient that's pregnant in this country, what can they do?
And I mean, and as you said, and as we said before, it's not always an option.
Mm-hmm.
Black female docs, we're 2%. Overall, it's 5%. 5% of doctors are Black, period, right? And then I think it's like 5% are Latinx and all that stuff. So like, there's not, you're gonna be in places that may not be an option for you. And so one big thing that I say that's really important is to verbalize your concerns. Yeah. And that's something that I've actually heard from a lot of my Black and brown patients, where they tell me, like, I've heard that my, people who look like me, people who are from my background have poorer outcomes, and I'm scared, right? Mm-hmm. And verbalize that. You can say that to a white provider or a white person, because I also think that we want to be like strong. We don't want to make other people uncomfortable. That's also another big thing, is that we've been taught that talking about our pain and talking about our concerns and our fears that are race-based is maybe a sign of weakness, or we don't want to be re-victimized, right?
Yeah,
Because the
yep,
other
yep,
part of
yep.
it too is that saying like, because I know one of the biggest things that I've experienced in my career at times has been like me saying that something happened to me because I was Black, and it was very obvious that it was. Like, I was called the N-word before, like, you know, in
Yeah.
a clinical situation, and I was told that that didn't happen, when
Yep.
I'm like, I was literally there and it happened.
Yeah,
So
I heard it. It happened.
yeah, and
Mhm.
it's like, and I get that, and I get that, you know, it's a concern of like, are they going to, or am I just going to be brushed aside? Am I going to be, you know, like, there's like a re-victimization thing to it that like I feel like
Yes.
people are scared to deal with. But at the same time, you might want to know that information before you have an emergency situation, before you're in the labor room with that that provider and whatnot, because guess what? They think the same thing. They thought it whether they verbalized it or not, so you need to know.
And we're going to get cut off here in a minute, but if you're a provider listening to this, we don't get these lectures. You have to recognize your own biases. You have to educate yourself on health disparities, what's causing maternal mortality. You also have to understand why people are afraid to come in as Black and brown individuals coming in pregnant. That means you're going to pick up a book and read, do a PubMed search and read. You have to know, because that will go a long way.
It will.
And it's very eye-opening, but you have to make the effort to do it yourself. Don't assume that you're above it because you're an MD. That you have no biases, because nobody is.
Because you're not.
Nobody is. It's a work. Just like you would work on your bedside manner, you work on your cultural competence, you work on your ability to address health disparities and to answer those difficult questions that your patients might have, because you're the only provider around and you're white and they're not. And they need to feel comfortable with you.
Yep.
Because you did the work. You put the time in to be able to have those tough conversations with them, because it's real. This is something that they're walking into every pregnancy worried about. Yeah. Whether we want to talk about it or not.
Yep. And it's our job to get them to a healthier outcome.
Yes.
You know that. That's what we train for, and that's what should be your first priority, your first goal, period.
And we can't be offended when they ask those questions like, well, why would you think I wouldn't be? No. Get beyond that.
Yep.
It's because they're scared and they're worried, and they have every right to be. Yep. So let them ask the questions and take the time, pull up a chair and give them the answers and talk to them about it.
Exactly.
It's the best thing you can do. It's you should never be offended by that.
You should.
It goes a long way. It goes a long way. It really does. That just to show that you care. I do it myself, but I've also educated myself and taken the time to do that. And we all need to do that. Because it does help, especially if you're like myself. You know, most of my patients, 91% are women of color, patients of color that I deliver.
Yeah.
And if I didn't take the extra time, you know, it's important for all of us to do.
It's super important. And it should be a top priority, because we're not going to change these numbers. We're not going to change these outcomes unless we actually take the time and do the work.
I said the other day, is we can do all these yearly required hospital-wide courses online where you just click through everything. That doesn't get rid of our biases unless we do self-reflection and think about our own selves and where we can improve. That's the only way it's going to change. That course is not going to change our outcomes for our moms and our pregnant patients.
It sure won't.
It's not. Okay. Thank you so much.
Yes, it was great chatting with you.
I apprient that. I really admire you. I think you're doing great things, and I appreciate you having this conversation. Thank you. I know we're both behind the scenes. We're totally exhausted right now with everything with COVID, but we do need to take a minute to talk about things like this, because it is important, even though COVID is kind of taking over our lives in more ways than one. But there's still other things going on, and there's health disparities with COVID too.
Oh, yeah. And people are still having babies.
And people are still having babies, yep.
And it's affecting, and COVID's affecting how that's happening for people from different backgrounds. So it's super important. It is super important.
Okay. Enjoy the rest of your week.
You too.
This will be up. I'll turn it to the podcast. I'll tag you. Don't worry. But again, I'm behind on everything because I have so much COVID stuff.
I hear you.
Okay. Have a great rest of your week.
You too. Take care.
Bye-bye.
Bye.